Good afternoon, good evening, or good morning, depending on from when or where you are joining us. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to CDC Public Health Grand Rounds for October 2017, Global Prevention of Neural Tube Defects. We have an exciting session, so let's get started, but first a few housekeeping slides. Grand Rounds has continuing education available for physicians, nurses, pharmacists, veterinarians, health educators, and others. Please see our website for additional information. Grand Rounds is also available on all your favorite social media and websites. Please send comments and questions to the Grand Rounds email box at grandrounds@cdc.gov. Want to know more about neural tube defects prevention? We have a featured video segment on YouTube and our website called Beyond the Data, which is posted after the session. This month's segment features my interview with Scott Montgomery. We have also partnered with the CDC Public Health Library to feature scientific articles related to preventing neural tube defects. The full listing is available at cdc.gov/science clips. And here is a preview of upcoming Grand Rounds topics. Please join us live or on the web at your convenience. In addition to our outstanding speakers, I'd also like to take a moment to acknowledge the important contributions of the individuals listed here. Thank you. And now for a few words from CDC's Deputy Director, Dr. Schuckett.
One of the great public health successes of the 20th century was the substantial reduction of neural tube defects due to fortification of food with folic acid. Folic acid is an established intervention that can prevent the majority of neural tube defects. Up to 85% of neural tube defects are preventable if women consume adequate folic acid before and during early pregnancy. Fortification of staple foods with folic acid is a proven, cost-effective way to prevent neural tube defects in multiple countries and settings. More than 35,000 birth defects were prevented worldwide in 2015, nearly 100 a day, making fortification a tremendous public health success. However, fortification efforts in many countries lag, largely due to lack of awareness of the burden of neural tube defects. There is a lack of reliable data to drive policy action and monitor prevention interventions, as well as knowledge gaps on how to effectively implement fortification in different contexts, such as those where staple food grains are not industrially milled. Despite its proven benefits and efficacy, more than 100 countries have yet to implement folic acid fortification. Each year, more than 200,000 babies needlessly die or suffer varying degrees of lifelong disability, even though these birth defects are preventable with folic acid. To address these gaps, CDC and our partners are working to advance birth defect surveillance across the world. In 2015, based partly on work done by CDC scientists, WHO published a guideline on optimal red blood cell folate levels in women to prevent neural tube defects. This blood test is used in the U.S. and many other countries to identify populations who remain at increased risk even after fortification is in place, allowing further refinement of fortification efforts. CDC is also working with partners like Helen Keller International, Food Fortification Initiative, and the Global Alliance for Improved Nutrition to identify and disseminate good practices for effective implementation of food fortification in various contexts. Just as diets across the world vary, so will the solutions to fortification. Working with smaller-scale grain millers to fortify their products, and educating consumers so they learn to look for fortified grains are both important strategies. Working with our partners, we can expand the number of countries fortifying one or more staple grains with folic acid, helping more babies be born healthy and improving the health of women and children worldwide. Thank you.
Thank you. And now for our first speaker, Dr. Krista Kreider.
Good afternoon. Neural tube defects, or NTDs, are a series of birth defects shown here that result from the failure of the neural tube to close during very early embryonic development. The The three most common types of neural tube defects are spina bifida, in which the lesion is located along the spinal cord, anencephaly, with the characteristic absence of parts of the brain and skull, and encephalocele, in which there's a sac-like protrusion. The neural tube formation begins in the first days after conception and is completed by day 28, often before a woman knows she's pregnant. While anencephaly is fatal, children with spina bifida who receive proper interventions and accommodations can go on to live full and productive lives. Their level of disability depends largely on the location of the lesion. However, there are substantial costs to the treatment of spina bifida, which will be discussed in a later presentation. If the neural tube defects can be prevented, the resulting benefits would be tremendous. As malnutrition was associated with an increased neural tube defect risk, micronutrients were considered candidates for prevention measures. One of these is folate. Folate is critical to basic processes in the body, such as DNA methylation and DNA replication. Folate is a general term used to describe the many different forms of vitamin B9. Folic acid is the synthetic form of folate, which, unlike the other forms, is not easily degraded by heat or light. Initially, folic acid supplementation was used to treat megablastic anemia. It was hypothesized that folic acid might help prevent neural tube defects, as replication and methylation are critical to early embryogenesis. In the early 1990s, two papers showed that folic acid supplementation could prevent neural tube defects. The first paper showed that 4,000 micrograms a day reduced the occurrence of NTDs in women with a previous affected pregnancy. The second showed that 800 micrograms a day of folic acid in a multivitamin prevented the first occurrence of a neural tube defect. The community intervention program in China, led by Dr. R.J. Berry of our center, expanded on these studies. The intervention was 400 micrograms a day of folic acid alone, and women were enrolled during their premarital exam. There were almost 250,000 informative pregnancies. In the high-risk northern counties of China, women who consumed 400 micrograms a day before and during early pregnancy reduced their NTD prevalence by 85%. While in the moderate-risk south, there was still a 40% reduction. This showed that the percent reduction in NTDs is dependent on the baseline rates, and that 400 micrograms a day of folic acid alone could reduce the risk, but did not prevent all occurrence, as NTDs have other causes. In response to this evidence base and other studies, the CDC, Institute of Medicine, and others made the recommendation that women capable of becoming pregnant should take 400 micrograms a day of synthetic folic acid, in addition to consuming foods with natural food folate from a varied diet. Earlier this year, the U.S. Preventive Services Task Force affirmed their previous recommendation for folic acid supplementation. There are three main challenges to neural tube defects prevention: timing, vehicle, and delivery. Timing is critical. As noted earlier, the intervention must begin prior to pregnancy and reach the highest risk women. The second issue is vehicle. It is difficult to reach the equivalent of 400 micrograms of synthetic folic acid with natural food folate, and it also requires behavior change. It is critical to note that although natural folate consumption is encouraged, folic acid is the only form of folate that has been shown in clinical trials to prevent NTDs. The third issue is delivery. Supplements containing folic acid are not widely consumed before pregnancy and do not necessarily reach the highest risk women in a given population. In the U.S., folic acid fortification of enriched cereal grain products, such as bread, was chosen as an approach to prevent neural tube defects because folic acid was known to prevent NTDs, was known to be stable, enriched cereal grain products were widely consumed and already fortified with other micronutrients, and thus did not require behavior change to ensure that women get enough folic acid prior to conception. In 1998, products labeled as enriched were required to add 140 micrograms of folic acid for every 100 grams of product. Here are the rates of anencephaly and spina bifida in the U.S. in the pre, optional, and post-mandatory fortification period by racial ethnic group. Following the implementation of Fortification, there was a 35% reduction of NTDs and a reduction in the racial ethnic disparities. However, there was no intermediate measure linking Fortification to NTDs, enabling easy short-term monitoring. One way to address this challenge was by identifying a useful biomarker, such as blood folate concentration. Red blood cell folate is a biomarker associated with both folic acid intake and NTD risk. As RBC folate concentrations go up, NTD prevalence goes down. Informed by this and other studies, the WHO, the World Health Organization, set a threshold for optimal RBC folate concentration for NTD prevention of 906 nanomoles per liter. Please note that this is much higher than the folate deficiency threshold of 305 nanomoles per liter for the prevention of megablastic anemia. It takes more folate to prevent neural tube defects than to prevent anemia, and these measures have distinct purposes and target populations. The WHO Optimal RBC Folate Concentration Guideline can be a useful tool to help us know how we are doing with our folic acid fortification and how we can make targeted improvements. These are the steps. Assess the RBC folate concentration distribution of your population, identify the need for an intervention, target the high-risk populations, implement the intervention, evaluate the intervention, and adjust the program based on the data. We are at the evaluation of a program step in the US as Fortification is in place. In the US, there are 3 sources of folic acid that are differentially regulated. The first is mandatory folic acid fortification of enriched cereal grains, such as bread. In addition, ready-to-eat breakfast cereal can be, but are not required to be voluntarily fortified. And finally, there are vitamin supplements. The majority of women of reproductive age in the US have at or above optimal RBC folate threshold for NTD prevention. Our most recent estimates show that 23% of women have suboptimal concentrations. When we look by source of folic acid, women with multiple sources had limited increased risk, while those with enriched cereal grain products, as their only source of folic acid in the US, had contributed disproportionately to the elevated and high-risk RBC folate concentrations. In the US, 40% of women of reproductive age have enriched cereal grains as their only source of folic acid. The optimal RBC folate concentration threshold results in the ability to assess and monitor folic acid fortification programs. In the US, it is shown that although most women are optimally protected, some of those consuming enriched flour and breads remain at increased risk due to low intake. Possible approaches that could be targeted to the higher risk populations include fortifying additional staples. Corn masa flour fortification began this year, and encouraging wider consumption of supplements containing folic acid. When RBC folate concentrations were assessed in Guatemala after the implementation of their fortification program, it was found that 47% of women of reproductive age were suboptimal, and that folic acid fortification was not reaching the rural, low-income, and indigenous populations, showing the guideline's utility in many settings. The remainder of the talks will highlight some of the activities of CDC's Birth Defects Count initiative. Birth Defects Count stands for Countries and Organizations United for Neural Tube Defect Prevention. The objective is to significantly reduce death and disability resulting from neural tube defects. Our focus regions are currently Southeast Asia and East Africa, where we see the greatest potential for impact. Our focus intervention is fortification of staple foods with folic acid. And this will now be discussed in more detail by Mr. Scott Montgomery. Scott?
Thank you, Krista, for that great presentation and the introduction. And thanks to the CDC for inviting me to present today. I'm going to discuss why we recommend fortifying cereal grains, the current status of grain fortification, and the opportunities. As Krista said, fortification is one way to increase the population's folic acid intake. In the U.S., you probably call this enrichment. To put it simply, fortification is adding vitamins and minerals during the milling process so that everyday foods are more nutritious. Note that we are not referring to biofortification or genetic modification. The vitamins and minerals are added at parts per million. They have no effect on the final consumed food's taste, appearance, or baking characteristics. Many foods can be fortified just as iodine's been added to salt for nearly 100 years. At the Food Fortification Initiative, our niche is the three most commonly consumed cereal grains: wheat flour, maize flour, and rice. Of 171 countries, 167 have greater than 75 grams per capita per day available for human consumption of at least one of these basic staple foods. When grains are fortified, people increase their nutrient intake without having to change their behaviors. Our focus is the fortification in industrial mills. You'll see that picture on the left is an industrial mill, not the one on the right, which is a village chalky mill in India. The technology for fortification in industrial settings has been used for decades. It can be sustained through standard operating procedures. The costs are incorporated into operational expenses. In many countries, industrial mill grains reach nearly all the population. I should be clear on my own background. I'm a miller. I worked in agribusiness for 30 years across the globe in wheat, maize, and rice milling. I understand the technology, feasibility, supply chain, and costs. In a few minutes, you're going to hear a presentation about technical options for fortifying flour in smaller mills. Now I'll move on to the subject for today, the success and opportunities of fortifying grains with folic acid to prevent NTDs. So, between 1996 and 1998, the United States, Colombia, and Oman began fortifying with 1.5 milligrams of folic acid per kilogram of wheat flour with the goal of preventing neural tube defects. Now, 81 countries in green require folic acid in their wheat flour, maize flour, and/or rice. Each country sets its standards for the amount to be added based on the population's typical consumption of grain products. So the great news is it works. An estimated 35,500 neural tube defects were prevented in 2015 due to fortifying flour with folic acid. This success is partly because it increases women's folic acid intake during that critical window of intake that Krista described, even before they know they're pregnant. Contrary to vaccinations, as an example, increasing folic acid intake cannot be done with 1 or 2 shots. Women need folic acid daily, and fortification prevents birth defects year after year. The cumulative numbers prevented will be enormous year after year. Even with that success, we've not arrived at where we want to be. We identified 79 countries with an immediate potential for large-scale mandatory fortification. In these countries, we estimated 201,000 birth defects are affected with spina bifida and anencephaly every year. Mandatory fortification would prevent about 80% of them. That would be 161,000 healthier infants every year. Among the countries examined, fortification in China, India, Russia, and Turkey would have the most significant impact on the numbers of cases prevented. So this chart shows the prevalence of neural tube defects before fortifying with folic acid in the purple and after in blue. The chart represents several countries with high-quality data. As you see, each reported a significant decline in NTDs. Another meta-analysis showed a range from 31 to 78% with overall reduction of 46%. The percentage decline will depend on the baseline. Where there's a higher baseline NTD prevalence, such as Chile, you would expect a greater percent reduction. Fortification's impact also depends on the amount of folic acid added and the reach of the fortified foods. Now I'll share a couple of specific examples. The first example is from Cameroon, where fortification improved the biological markers for folate, vitamin B12, zinc, and iron. You'll note on the slide the increases in all of those vitamins and minerals: folate, B12, zinc, and ferritin. In Fiji, studied the results of wheat flour fortification using mean blood serum levels and World Health Organization cutoffs for deficiency among women. During the study period, no other nutrition intervention was implemented. Notice the improvements in iron and zinc deficiency and percent of women with anemia, as well as the reduction in percent of women with folate deficiency. We are focused on folic acid today, but remember that flour can be fortified with multiple nutrients. It's one intervention with multiple outcomes. So moving to the cost-benefit equation for fortification with folic acid. 3 countries have compared the cost of adding folic acid to flour with the cost of treating people with spina bifida only, not anencephaly or the other neural tube defects. Each study showed a significant net savings in healthcare expenses when spina bifida was presented. Notice these are annual savings, so every year of fortification leads to these net savings. Another way to look at this, more the language that I historically would speak, is to compare the cost of fortification with the savings in the private sector. We called this the return on investment or payback. In the U.S. example, for every dollar spent on mandatory folic acid fortification, the healthcare savings are 48 times that investment. Each example here is an incredible return on investment. Now to discuss the opportunities. The first line in this table is the amount of cereal grains in millions of metric tons available for human consumption. The second line is the amount of those cereal grains that are industrially milled. And the third line is the metric tons of industrially milled grains that are fortified. So in gold, summarizes this as a percentage of industrially milled and fortified grains. The opportunity is to get these percentages to 100. The countries on this map in red are places where fortifying grains with folic acid could have a tremendous impact. These countries have an industrial milling complex, high grain consumption, and they are not currently fortifying all commonly consumed grains with folic acid. So in conclusion, there's 35,500 NTDs are prevented globally per year where flour is fortified. The opportunity is to prevent another 161,000 each year through grain fortification, resulting in nearly 200,000 healthier babies every year. Quoting a miller from Indonesia, fortification creates something of enduring value. The costs are minuscule and the benefits are enormous. Thank you. And now it's my pleasure to introduce Aaron Smith.
Thanks very much for the opportunity to come and present to you today. For me, I'm presenting on something completely different. I mean, it's still neural tube defects and fortification, but we're looking now at a smaller scale at these small-scale mills. So it's I'm just giving you a case study on something that we've done. So there's been a lot of progress made in nutrition indicators over the last 10 years. Essential micronutrient deficiencies remain high in Tanzania. 34% of children are stunted, and anemia, iron deficiency, and vitamin A deficiency are still prevalent in women and children. Under 5 mortality is also high at 81 per 1,000, which is 1.7 times higher than the world average. Blood folate is not an indicator that's currently measured on any national nutrition surveys because the country currently lacks the capacity to do so. But a recent agreement between CDC and the Ministry of Health is going to start a surveillance lab, and that's something that we will also be using in our future research to understand the biological impacts of our intervention. A review of NTD's incidence in neonates in the largest hospital in the country revealed a rate of 30 per 10,000 live births, or roughly 4,840 new cases per year. The picture that you see on the slide is a child named Faraja, who is one of our case studies. So that basically is 4,840 new cases like Faraja per year. These numbers are likely an underestimation. Children and parents affected by NTDs face a high level of stigma from the community, and healthcare workers who are trained to manage complications of NTDs are few and difficult to access. It's likely that a large number of cases never make it to a facility for diagnosis. As we've heard, food fortification is a method which is proven to be successful in defeating micronutrient deficiencies in a cost-effective way, so long as the product chosen for fortification is widely consumed, easily fortifiable, and affordable. Tanzania brought laws and regulations on board to make fortification of staple foods mandatory in 2011, selecting wheat, maize, edible oil, and salt as vehicles. But the law applies only to large-scale industries. Currently, all 13 large manufacturers in Tanzania are fully equipped to fortify wheat flour and edible oil produced at those sites. However, quality control testing has shown variability remains in industry compliance with national standards. Maize is the most prevalent staple food in the country, and it's not processed industrially. So in reality, its production is unaffected by the law, the current law. To confirm that maize is the most consumed staple food in Tanzania, we looked to the Fill the Nutrient Gap study done by the World Food Program. This analysis looked at cost and diversity of average diets, measuring the percentage that each major food group contributed to the daily diet. On average, 40% of energy was provided through maize, 15% through wheat, 11% through roots and tubers, and the remaining 36% of energy in the diet was provided through proteins, fruits, and vegetables. Seen another way, the average diet relies on maize for more than 2 times more energy than any other food. Yet nationally, maize is 83% less likely to be fortified. Why? The answer is, up to now, maize fortification in environments like Tanzania has been very challenging. The maize production industry is highly fractured, with the bulk of the product being produced at multiple small and medium-scale enterprises throughout the country. There's only 2 large-scale mills that are producing maize flour, and the bulk of that production is going to the beer industry for brewing. The majority of maize produced for household consumption is produced at the small and medium-scale processors like the chalky mill that Scott referenced. This is done either through more established packaging millers who produce in bulk and sell their product on the market, or through village toll millers who provide a milling service for households who supply their own maize for a small fee. At the start of our program, and even now in most of Tanzania, small and medium-scale millers had very little motivation to consider fortification. The law doesn't include them. Consumers aren't demanding the product. They're not aware of the benefits. Technology and micronutrient mixes are expensive and difficult to get, and if they start to fortify, they'll be unable to pass the increased costs over to the consumer because of market competition. What's more, many poor and rural residents, at least we assume, are making their own maize flour rather than purchasing, so we're not even sure that we'll be reaching the population that we're trying to reach. So with these challenges in mind, the HKI team, together with our technical partner Sanku, sought to determine what would it take to successfully support maize millers who package their flour, these 10,000 small and medium-scale industries, to make sure that they're fortifying their product and that the population who needs the fortified product are getting it. Would they be able to be compliant? Can we find a way to make it cost-effective? Can the target population at the bottom of the socioeconomic scale benefit from this maize that's being produced at the packaging mills? In 2015, HKI teamed up with Sanku to answer these questions. Sanku is a technical partner, and they provided the business model for millers, the equipment, access to premix, and other essential inputs, all to help the millers operate successfully. By March of 2017, Sanku had successfully integrated 71 maize millers into the program, up from roughly 27% at the baseline. HKI worked with district and regional governments, lawyers, the Tanzania Food and Drug Authority, district nutrition officers, all to draft legislation in the form of a bylaw specific to the small and medium-scale enterprises in Morogoro. This bylaw sets standards and practices to guide those millers and enforcement bodies. HKI also worked on advocacy in government offices, schools, health facilities, and in churches to ensure that the structural and systemic support that's necessary for fortification is existing in the area. Through community mobilization, radio, and print media, we launched an education campaign to raise awareness, reduce stigma, and decrease popular fear-based myths around fortification, and also to build a perception around quality around the logo. Finally, to assist millers with compliance with national food production standards, we developed tools specific to fortification enforcement for the SMEs and trained local enforcement officers on their use. So we wanted to determine if this whole package was effective in reaching our goal. So we carried out a baseline study before we started, and then we've carried out exactly 1 year later what we called an end-line study. The data was collected digitally by trained enumerators and was done in collaboration with the CDC and with the GIZ, the German Development Organization. We were looking to assess changes in acceptability, purchasing and consumption patterns, and to understand household-level access to fortified maize products over that 1 year time. And we saw a significant change in people's attitudes around fortification after the 1 year. Respondents' knowledge of fortification and ability to identify the logo increased significantly. More people were able to identify at least one benefit, and more were willing to purchase fortified maize. Respondents also reported that seeing the logo on packaging positively influenced their decision to purchase a product. We were surprised to see a dramatic change from baseline to end-line in the numbers of households purchasing their maize versus the number producing it at home or at a toll mill. And I mentioned earlier that we weren't very sure what the sort of bottom of the socioeconomic strata were doing in terms of their access to maize. So we were really surprised to see that households who purchase packaged maize increased from 62% at baseline all the way up to 82% at end-line. And then households producing their own homegrown maize decreased from 34% to 17%. And this was based on respondents' answers at the household level, and it stayed consistent when disaggregated by wealth. Part of our sample selection included actual flour samples at the household level, and both at baseline and end-line. So we selected a small amount of flour and sent those tests into an independent lab to see if there was fortification in the product that we found at the house, and how it measured against national standards. We saw an increase from 3% of flour, which was adequately fortified at baseline, to 63%, which was fortified according to standard by the end-line. An additional 27% of flour contained higher than recommended levels of fortificant. So that could just indicate a sensitivity on the test, but it means that there was actually fortificant in that sample of flour, and none of them were above dangerous levels. So essentially, we saw an increase from 3% of fortified maize found at the household to 90% in just 1 year. Another dramatic impact that we saw was in access for poor households. At end-line, 81% of households classified as poor using the multidimensional poverty index reported purchasing packaged maize flour regularly. As I mentioned, we selected samples at the household level and found that among poor households specifically, 94% of the samples collected were adequately fortified. So if collected samples are representative of the poor population of Morogoro's maize purchasing habits, it means that as of the end-line survey, 72% of poor households were accessing fortified flour in Morogoro. So the data shows that a concentrated, multifaceted campaign and increased production can change purchasing patterns in the short term, but we really wanted to make sure that this intervention was also sustainable. So in 2016, we worked with stakeholders working with the small and medium-scale enterprises and with district officials and local government to design and pass a bylaw to bring all maize flour producers in the district under the main fortification law. So the law would make fortification of maize flour with iron, EDTA, zinc oxide, folate, and vitamin E and vitamin B12 mandatory for any maize flour produced or sold within the district boundary. The law passed in September 2017, and we're currently working on enforcement guidelines. Prior to this intervention in Morogoro, maize millers were dropping out of the fortification program because there was no market for fortified food. With just 1 year of intensive advocacy, education, increasing the number of participating millers, and adapting a supportive legal environment, including the passing of the fortification bylaw, access to fortified maize flour increased from 3% to 72% among poor households in Morogoro. We saw a shift in purchasing behaviors among all respondents and found fortified maize in 72% of poor houses in our sample. These findings challenge the idea that working with packaging millers will not reach the poor. This pilot project shows that fortification can be successful among SMEs with a small investment and with the proper framework leading to improved market demand, improved access to product, higher quality production, safer food products, healthier population, and fewer cases of neural tube defect. We're now going to be we're now looking at the potential for scale up. So I'd like to take this opportunity to say thank you for your attention, and I'd like to introduce our next speaker, Dr. Reina. Thank you.
Good afternoon, ladies and gentlemen. In next few minutes, I'll be sharing with you our experience in Southeast Asia region, which has 11 countries, on surveillance of bird defects. As we have heard our previous speakers, that there are a large number of countries where fortification ought to happen, but is not happening. And if we look at India, with the largest population in our region, which is estimated to hold 1/3 of the world's NTDs, is the prime country for this kind of an intervention. But there are challenges due to fragmented fortification. Many staple foods, like I think we heard my previous speaker, are not centrally milled. There are small chakis in the villages, and that makes the fortification efforts more difficult. Food Safety and Standards Authority of India, FSSAI, set initial fortification standards for micronutrients, and which we found were too low, especially the folic acid. In 2016, WHO Sero, CDC, FFI, and other partners led a successful effort to have FSSAI amend standards to align with WHO global standards. And you can see the ministers and the secretaries from different departments releasing this notification. I think we have come to understand one thing very clearly, that surveillance is the key to prevention. And to understand the impact of fortification and to demonstrate reduction in number of NTDs, and even to advocate with the countries to start fortification, we need data. And WHO Sero and CDC collaborated to develop a reliable bird defects surveillance system. And our collaboration is 6 years old, started in sometimes in 2012. We started with regional strategic framework, and I'm pleased to share with you that 9 out of 11 countries of our region have now national plans for surveillance and prevention of bird defects. Ministries of Health spearheaded this whole process. In 2014, we launched SARE NBBD, Newborn and Bird Defects database, which is an online database, and there are a large number of hospitals which have started to report. We started with only 13 hospitals in Bangladesh, Nepal, and India in 2014. And we stabilized the surveillance system. And today we have 146 hospitals in 7 countries of our region which are submitting the online data. We have another 108 hospitals in 3 countries, which is Indonesia, Sri Lanka, and Timor-Leste, which are using the same format, but they are collecting data at the country level in these hospitals. So it is the only surveillance network of its kind in the region. As you can see, the spread across the region in different countries, and there are standardized forms which are available online and through the mobile app. So there are 2 options are there with the countries. We have built capacity of surveillance of bird defects in our network hospitals. We have conducted large number of meetings of the stakeholders where ministries of health had chosen these hospitals and took the ownership to ensure that these hospitals upload the online data on a regular basis. Verification and quality monitoring of data is done on almost daily basis. As I said, it's a unique surveillance system. It's a hospital-based surveillance system with a predefined inclusion criteria. All hospitals are required to identify and report all bird defects that occur in the hospital and report monthly denominators, including the number of stillbirths which happened in that hospital. The quality assurance of surveillance is done at all levels, which is hospital level, the network, because we have national coordinating hospital in every country, and at the regional level, which is our WHO Collaborating Center for Genetics, which really looks after the quality of data at the final level. Involvement of Ministry of Health in every country has really helped us deal with this data more efficiently and effectively. So this is where we are today in 146 hospitals, which accumulated and increased over a period of last 3 years. Total births which have been reported online is 1.6 million, and over around 16,500 birth defects in 14,000 children were reported. There are strengths because, as you know, in our region, we have encouraged ministries of health to really draw up schemes to encourage women to deliver in the hospitals, and there are countries where hospital deliveries have increased up to 90 to 100%. So it's a hospital-based system with few limitations, which we all understand well. If we look at the distribution among birth defects across, which were reported, we find that 67% of all birth defects are in the nervous system. I think it's not a surprising finding for us. And among stillbirths, 52% are in the nervous system. And I think and only 14% are among the live-born babies. If we look at the 8 visible birth defects which are reported, of these, 40% of the visible defects were neural tube defects. And 52%, which I showed in my previous slide, half of the birth defects detected in stillbirths were NTD, of which anencephaly was most common, which was 55%. And at 14% of NTD were less frequent in live births. However, the NTD seen in live births, Spina Bifida was the most common, which was 69%, as shown here. So one message is very clear. If we look at birth prevalence of NTDs only amongst live births and miss out on stillbirths, we miss out on large number of neural tube defects. So we look at the data for starting 2014 onwards for completeness, timeliness, and the description and the correctness. And we find that over a period of time, I think we are getting better and better, and countries are really focusing, the hospitals are focusing much more on the quality of the data which they submit. We were quite intrigued by this finding that stillbirths are the ones where maximum neural tube defects are found. And we know that there are large number of countries in our own region where abortion is legal. So we started in 10 hospitals in India where pre-viable and stillbirth birth defects, where autopsies were also carried out on stillbirths to find out about the more birth defects. We started in 10 hospitals and increased it to another 10 in 2015. And today the government of India has taken this decision to increase it to 55 hospitals, and Bhutan another 3 hospitals. I don't have time to share the data on pre-viable, but about 60% women who came for termination after ultrasonography, NTDs were the main reason. So what are the key lessons? I would focus on only major 3 key lessons. One is ministries of health need to be engaged, and their engagement is very crucial for sustainability. And their engagement is not an easy task. It took us a long time to really get them interested and take the ownership for this data. Focal points with clearly defined roles for birth defect surveillance are important for smooth operations. Every hospital had a focal point, either from pediatrics ward or from OBGY. There was somebody who was responsible for any problem which occurred in the surveillance system. I think periodic refresher trainings, regular meetings, engagement with them in terms of webinars. You can see e-blast, which we send every month, and a newsletter which is sent quarterly. I think the focus on quality of data and the use of this data, converting this data into information, and letting the hospitals become the champions for advocacy for prevention is the key. And that makes our system very, very unique. So we know that, fortification is important, but then there are knowledge gaps. And India is getting ready with this fortification efforts. So we have started in collaboration with CDC a project in Haryana, one of the states in India. Phase 1 is almost over. Baseline household survey has been done, biomarkers test has been done, community need assessment is complete. We'll be ready with some of the results very quickly with you and share with you. Phase 2 and phase 3 are still pending to be started. My last slogan is prevent birth defects, improve newborn survival, ensure quality of life and dignity. Thank you very much.
Take questions. Susan?
Our online audience seems to have some confusion as to the difference between folic acid and folate. So we have several comments on that, and I was hoping you might be able to provide some clarity.
So folate is a general term that's used to describe all the different forms of vitamin B9. So every single one of the vitamins is called a folate. If you're talking about a specific subform, folic acid is one of the specific subforms. There are other forms such as 5-methyl-THF and the like. So it's somewhat confusing for an outsider, and it's actually somewhat confused in the literature itself. Somebody.
Hi, this is Yinita Reifas from the Defects branch. So I have a question for Mrs. Smith. I was wondering whether there was what the level of, percentage-wise maybe, of price difference there was between the unfortified and the fortified by the small millers. I was just kind of curious if that was an influence at all.
Yeah, thank you. Actually, that was a big challenge that we had to overcome. Initially, there was a small, I think 2% price increase between the fortified and unfortified maize, but even that small increase, people were not willing to pay. So initially, we really had to come up with some creative ways to either subsidize the cost of the premix or to decrease millers' costs in other ways to make up for that difference so that on the market it would be the same price. Eventually, we're hoping that as awareness increases and as people are more willing to demand a fortified product, that won't be an issue anymore and that cost can be passed on. But to date, we've sort of subsidized through offering other things to the millers.
Godfrey?
I just want to say what a wonderful job you did. It was just an absolutely fantastic presentation. And just to emphasize what an incredible, important prevention opportunity this is. There were 6,000 Zika birth defects, and we have 200,000 folic acid preventable birth defects every year. It's a huge opportunity that we should move on as fast as we can. And as ammunition to support that with the ministers of health, it looks like to us that about 10% of the Sustainable Development Goals worldwide for children is attainable simply by maximizing folic acid preventable spina bifida prevention. And so those two things really ought to help get us off our backsides to get this done. And I think the way off our backsides is to treat this as the way the vaccine people did. In 1991, we got the vaccine to prevent folic acid preventable spina bifida. We're at 15%. Since 1991, the vaccine industrial complex has delivered 4 brand new vaccines to more than 90% of the world's children. We've got to do something more like what the vaccine people do, and maybe it's to have the enthusiastic support of the CDC director to get it done.
Susan, do you have additional questions?
Yes, and I do want to remind our online viewers to go ahead and submit your questions to grandrounds@cdc.gov. Next question is, any idea about neural tube defect status in West Africa, say like Sierra Leone and the entire region on the whole? And will such fortification food supplement programs be extended there?
We have very little information from West Africa. Do you know anything, Erin?
I don't know the statistics, no, but I do know HKI has a large fortification program there that's working with industrial industrial milled products. And so there are interventions that are active in West Africa, throughout West Africa, but in terms of prevalence, I don't know the data off the top of my head.
Hi, thank you very much. This is Colleen Boyle from the National Center on Birth Defects and Developmental Disabilities. I wanted to thank our wonderful panel. So I guess to follow up on Dr. Oakley's question and challenge you a bit, what do you see as perhaps the one or two opportunities that we have now to move on prevention? Obviously, resources and financing are always a challenge, but maybe putting that one side aside a little bit and thinking about what the opportunities are out there. So maybe start with Scott and Aaron and Nina, and we'll follow with you, Krista.
One, it's hard to put financing and resources aside. Building political will, I mentioned this morning, and beyond the data, that's one of our big challenges. So convincing, getting to that executive level of government, I think, is, the ministers of health are on board, to my knowledge, almost every country, but they don't have decision rights. So anything we can do to get cross-ministerial support, whether it's the Minister of Finance, Minister of Agriculture, Minister of Industry, and more importantly, the executive branch, if we can find champions to support the efforts in countries, they'll push it. Outsiders coming in, we can supply technical support, but we need that in-country champions and support to really move forward.
Yeah, I think from our perspective, I agree very much with what Scott said. And I think in terms of, from our perspective, you really need to focus on the things that people are eating and making sure that you have an effective way to fortify those products and get them out into the market. So from my perspective, the kinds of stuff that we're working on, the pilot that we're doing, expanding that and looking into how to make it more impactful, maybe more affordable. I think that is a really important intervention for areas like Tanzania where there isn't a lot of industrial scaled milled products, but there is a lot of need.
I'm wondering.
I think fortification is not something which is new to the ministries. Look at iodized salt. The fortification, the whole thing was driven not by industry, but by the Ministry of Health. I see that wherever the fortification pilots or demonstrations are being done, invariably ministries of health are not even aware of it. It's between the millers and some other, people, something goes on, so they don't even know about it. So that's, I would say, a major gap if we want to really, and how to convince ministries of health. And that was the reason from the very beginning, we involved the ministries of health in the surveillance so that they see their own data. They don't believe on estimates. 2006 March of Dime report, they said it's trash. We don't believe in it. To be truthful, they want to see the real data from their own hospitals. So there are two advantages of involving ministries of health in surveillance. One, most of these large so-called tertiary level hospitals which have network coordinating centers are from the big professional associations, and they are the champions, and they can convince the ministries very easily. So that's one part I would say that we must use that track to really use surveillance as key to prevention. And the second is something which we were able to, even before our neural tube data started to come out, we started to convince the ministry, especially in India, that anemia is your major problem. So you have put in iron folic acid supplementation for 50 years, and you have not seen even 5% decline in anemia prevalence. So why don't you start with iron, B12, and also add folic acid, because it will help neural tube defects. So they really jumped at it because they've been struggling for so long, that whether it is iron folic acid supplementation is a problem or what is the problem, we have not been, because the compliance is very poor. They distribute millions and billions of tablets, spend a lot of budget, but they're not seeing the impact, and they were being questioned why this is happening. So I think that was a very good entry point for us to bring Ministry of Health on board. And Dr. Colleen was there when they organized a national consultation to roll out fortification and really convince FSSAI. FSSAI is part of Ministry of Health. So they came up with standards, and now is the real challenge. If we only focus on millers and don't have any innovative approaches to get this through the PDS system, and also find some innovative ways to address chuckies, behavior change takes long time. So let's get started. Let's invest. And now they want to see how part is missing. You know, the experiences we have are big millers, where, like US, you can immediately supply every home it can reach. But in a country like India, I think it's very important for us to show some implementation science research. How do we operationalize in a given setting? And Haryana project is a wonderful opportunity for us, where we have just finished the baseline survey. Ministry is ready to invest for the fortificant part, but they want us to monitor and tell them what are the processes, what are the learnings before they scale up to the rest of the states. Thank you.
Thank you, Nina. Do we have a question in the back?
Yes, hi. Chris Braden from NC EasyID. It may not work in a very in a society or a country where there's the milling is very fractionated, but also where retail is very fractionated. But I wonder about opportunities to work with private sector, especially the retail stores, to add to their purchase specifications that the product that they are selling is fortified. And any experience with that kind of partnership?
No, that's an excellent point, and it's one of the things that we learned in throughout our process is that it's not enough just to get the product created, but it also has to be available to the public. So one of the things that we've done, it would be really difficult to get those specifications legalized, because already enforcement is very difficult, and so to ask the government to be enforcing the market level would be very, very challenging. So instead, what we did was we got this kind of cadre of people that we call point of sale agents, and we trained them on fortification, and then we asked them to go to different shops, and we basically worked with them on commission. So they went to a shop and they had posters, and then they were supposed to educate the shop owner about fortified foods and what the benefit is and where they can purchase them, where they can get the supply. And then if the shop owner agreed to put a poster up, then they would get a commission for that. And if the shop owner agreed to start selling the product, then they'd get another commission for that. And we saw, just in 1 month of kind of trying that out, we saw the amount of fortified food that was available on the market went from 30 shops, which were selling fortified product, to 85. So it really worked really well, and it's a really important point that we really hadn't considered initially. Like, how do you make sure that that product is available?
Yeah, I think even in advanced countries where you have large retailers, some of those retailers are actually could be amenable to adding that to the purchase specifications of their product voluntarily, and so they can reach then the hard to reach populations even in more advanced countries.
Yes, my question, actually, you touched upon it a little bit in your response, but it has to do with the Shaki versus the industrial mills, and whether or not if the industrial mills are putting the Shakis out of business, or is there a relationship in terms of working with them to modernize their own facilities to whatever degree, somewhat like in countries where, for instance, they're working with local growers for coffee, and you see those products in markets even here in the United States and things like that. Is there a collaborative effort between those Shakis and the larger mills to make sure that they can stay in business? Because I think that would also enhance the likelihood of, increased both awareness as well as desire to bring these kinds of things to market, because they won't feel like they're putting their family members or friends out of business by going with those industrial products.
Yeah, that's a great question and a great point. So what we're really focusing on these small-scale millers, and we're not So the large-scale industry is already focusing on wheat, and they focus on edible oil. And as I said, there's only, I think, 2 millers that are doing maize in Tanzania. And it's interesting because there's a difference in preference. So at the large-scale mill, there's a different technology that's used to mill the grain. And the general population doesn't prefer that product that is produced as a result of that process. At the small scale, they use what's called hammer mill technology, and it's basically a bunch of hammers that pound the grain until it becomes a really fine grain flour, and that's what people prefer. So even without any intervention on our side, there has been a movement away from the large-scale industrial processed flour in Tanzania. So I think that's one thing. So what we're trying to do then is empower those small-scale processors to be able to produce a higher quality fortified product. So not put them out of business, not move towards the large-scale industries, but find a way that's affordable and reasonable to work with those small-scale so that they stay in business, but that the quality of the product that they're putting out there is better.
And that's all the time we have. Thank you very much to our speakers, and thank you for joining us.